So I'm Sarah Jones, and I'm the CEO of PMD Alliance, and it is truly my pleasure to be here with Dr. Mehta, who I miss terribly because of course, I haven't seen him in well over a year now, and he's with Mayo Hospital, but I'm going to introduce him in a minute here. First, for those of you that are new to us, I just want to give you a quick overview of what's going to happen in this. If you're new to us and you haven't been on Zoom, which is probably unlikely at this point, but just in case, if you go up to the top right corner, there's a little button that says view. And if you hit the view, you're going to either get gallery or speaker. And if you hit gallery, you're going to get the Brady Bunch view. And if you hit speaker, you're going to get my big face and then a small little view of people. So however you want to see it, I always love the Brady Bunch view because then I get to see all of you. But down in the middle bottom, there's a little chat. If you click that, you can type in questions as we're going, as Dr. Mehta is speaking and presenting. You can type in questions. You do not have to hold them to the end. Just type them in. I'll keep track of them. So that's the nice thing. You don't have to remember them. You can just put it right in there. I'll keep track of them and I'll ask Dr. Mehta. And then also, once he's done with the main presentation part, we are going to open it up and let you unmute yourself. So if you want to ask Dr. Mehta a question out loud versus typing it, we welcome you to do that as well. So this is definitely going to be a highly interactive hour. That is really our intention. This is our first DBS program, I believe, of this year. But I am really excited to introduce you to Dr. Mehta. He is a neurologist and movement disorders specialist, and he is at Mayo Clinic in Scottsdale, Arizona. He has expertise in brain stimulation for various movement disorders, including Parkinson's, tremors, dystonia, essential tremor, and Tourette's syndrome. And he also, I just got to notice my internet is unstable, so hopefully this is working. He also does botulinum toxin injections for dystonia, salaria, and spasticity. He provides ongoing care for patients with Parkinson's disease, as well as research in these areas and other movement disorders. He really focuses on education and helping the patient understand the disease and empowering them to become partners in managing their health. I did share with Dr. Mehta because I've actually really been having the true, I don't know if pleasure is the right word. You all know because you guys share in we all have medical things that we navigate. Pleasure is the best word I'm going to come up with. But my experience of Mayo Clinic that I think makes it really special is that the physicians are able to spend just a lot of time with you. You can really have in-depth conversations. It's not 10 minutes that you get with the doctor, and that really allows the doctor to understand you, help you understand the disease that you're dealing with, and really help you find a way to navigate it. And that's something that means so much to Dr. Mehta, I know. So we're really excited to have him here with us. He has such great expertise, and he's going to talk with us about DBS. And he's also going to talk with us about brand new, something that is out and available now, and that is remote programming. So I think we called this remote control. So I am going to turn this over to Dr. Mehta, and we will have more conversation after he kind of gets us all on the same page about DBS.
And he's very good.
He is very good. I agree with you, TK.
Sir. How are you? Nice to see you. I see some familiar faces, so that's awesome. That is, hey, so that is very nice to see some friends in the audience there. I can just in the short screen that I have, I already know 2 or 3 people there. So this is very, very nice. So good morning, everybody. Thank you for taking the time to attend this this meeting. I hope you get some important or fruitful or useful information out of what I'm going to say today. Obviously, this is, I take care of a lot of folks, and I've with Parkinson's and essential tremor, and I've got to know them and got to know their families over a period of time. So this is something that I really enjoy doing. I'm going to just shed some light on a modality of treatment, a surgical modality of treatment called deep brain stimulation, or DBS, which some of you may be aware of and know a little bit here and there, and some maybe not. So if it is too basic, I apologize. If not, just bear with me, okay? So I'm just going to share my screen. And so I don't know because I'm seeing two screens.
Oh, I bet you're in presenter view instead of slideshow view. Yep. If you go into slideshow view, that's really kind of the only way I think on Zoom, unfortunately. Yep. If you go under slideshow, yep, play from the beginning.
So right now, what do you?
Yep, over just a little more to the all the way to the left.
Hold on 1 second.
Yep, there you go. That should do it.
What do you see now? Because I'm
that's
seeing
weird.
two
That's
screens.
it keeps showing you, the presenter view. I don't know exactly what. Do you know, Kelly?
Dr. Mehta,
In the car, but I'm going to Publix.
you can probably click on the there you go.
Can you see now both the
Yes.
Yes,
just one
perfect.
screen?
Yes.
Is it good? Okay.
Yes.
So
you're great.
so these are my disclosures, basically, the relationships that I have with industry and the research that I do. So the grants that I have through Michael J. Fox or the International Essential Tremor Foundation. Also, I just wanted to get a sense from Sarah. Sarah, I know there are, I see some of my folks with Parkinson's disease. Are there patients, did you send it to include patients with essential tremor as well? Or?
Yes, we did. We sent it to the Essential Tremor Foundation as well. Mm-hmm.
Okay, so perfect. So I'll because I'm going to touch on both, and I just wanted to get a sense if we didn't have essential tremor, then I would just, move on. So
yep, no, we should have both. Yep.
So what is DBS? And we'll get into more about when it's done and what not and I'll touch on the Parkinson's aspect, and I'll touch on folks with essential tremor, because it's different. Those are two different disorders. So, but what is DBS for people who are not familiar with it? So basically, it's got three components. It's got the lead, which is an example of a lead. This is a Medtronic lead. This is the structure of a newer lead called a directional lead that's made by Abbott and also by Boston Scientific. So that's that part is the lead that actually goes inside your brain. Extension is a wire that connects the lead to the neurostimulator or the implantable pulse generator, or the short form is IPG, or the battery, which is implanted like a pacemaker, like in the patient's chest, which is what powers or drives the stimulation. So those are the basic three components of this DBS system: the lead, which is implanted in the brain; the extension or the wire, which connects the electrode to the battery. Okay. Now, and I think it becomes clear in the next slide, and we'll come back to it. So, using electrical stimulation, and again, I got this slide from Abbott in full disclosure, researchers were using electricity and stimulating different areas of the brain back in, close to 100 years ago now. But obviously it was very experimental. It was, quite Frankensteinish. And not ready for, prime time clinical use and things like that. But as you can see, in the 70s, 80s is when the DBS prototypes were developed. And also this was brought about by the advent of what's called microelectrode recording. So that's how we here at Mayo Clinic perform DBS, where, because we talked about putting the electrode in the brain. If the electrode, be it for Parkinson's disease, be it for dystonia, be it for essential tremor, if the electrode is not in the right spot, it's like real estate. It's all about location, location, location. If the electrode is not in the right spot, then the results are not going to be good. and you may not get all the benefit that one hoped to get from going through this procedure. So with the help of microelectrode recording, we are able to find the best tracks and identify the most appropriate location to where put the lead in. So, this developments happened in the 80s, 90s, and that's what pushed DBS into the forefront in terms of managing tremor or in terms of managing Parkinson's disease, especially for patients who were on multiple medications and the disease had continued to progress and were not being adequately controlled with therapy. So in 90s, 2000 is when they got approval, and then we've been using now DBS has been around for 20 plus years, close to 25 years. And in the last few years, there have been, again, significant developments in DBS in terms of better technology, in terms of better hardware. One of the main development being that of the directional lead, or directional DBS. And I'll show you that, in the previous electrode that we showed. So with most of the electrodes, you see that it's a complete ring. So the electrode that goes in the brain has a complete ring. Then this is the example of a Medtronic electrode that we had been using for the past 15, 20 years even, which has a full ring, and we can selectively turn one or the other on or off. And when we do the programming, when myself and my DBS nurses, when we do the programming, these are the different parameters that we can change and program to deliver current or voltage in what strength, at what frequency, and things like that based on the patient's symptoms. So the typical electrode that we've been using for the past 15, 20 years had basically 4 rings that we could turn on or off. And when you turn a ring on, it would send current in basically all the different directions around that. So it would stimulate the tissue around that. So in the last 4 or 5 years, there's been developments, and we've had what's called directional DBS, where the first and the fourth electrode ring, the ring is a full one, but the second and the third is segmented. So it's also called a segmented electrode, where it's not a full ring. So I could turn on just one segment or the other or a third one and steer current a little bit better in one direction as opposed to the other. And the thought process behind that, or the hope and the rationale behind doing that, is that we would be able to get better therapeutic control or better control of the symptoms without causing as many side effects by not stimulating unwanted areas, which when it's a full ring, we can't control it. It's going to go in all directions, and we may be stimulating areas of the brain that we don't want to. So with the directional stimulation, that's the advantage. Also now, for example, Medtronic, which still has the ring electrode, they've come out with another system where it can sense the firing pattern, and we can store that data and use that to also change programming and stimulation. And I'll touch on that in a minute. So in Parkinson's disease, and again, some of my patients some of the folks who are my patients who I work with on a regular basis may know some of these things. So when is the right time for DBS? When everybody gets first diagnosed, obviously we're not going to talk about deep brain stimulation at that time because the symptoms are very mild, can be well controlled with medications. But as years progress, as the symptoms continue to progress, and they've been on multiple medications and begin to notice what are called motor complications, for example, wearing off, where the medication doesn't control the symptoms as well, or the symptoms come back before it's time for the next dose, or they have what's called unpredictable on or off, where they took the medication, but it didn't kick in and they didn't notice any benefit. or they develop dyskinesias. And this is something that can happen, later in the course of the disease, where when they take levodopa or even other dopamine agonists, they have involuntary movements. If anybody's seen Michael J. Fox, you know what I'm talking about. But when they cut down on the dose to get rid of the dyskinesias, they are off. Their symptoms of Parkinson's disease act up, and they notice, the shuffling gait, the tremor gets worse, or their movements are slower, and they are at risk for falls because of shuffling or freezing and things like that. So, at this point, they usually have been on multiple medications, have been tried and titrated and adjusted. And, some folks may not been able to tolerate one medication or the other and things like that. And so at that time, it is an appropriate time to start the conversation about DBS, because it's all about getting them the best quality of life that they can. And a lot of times it takes DBS and medications both together to be able to achieve that. Now, typically we have been able to reduce the dose of the medications after DBS in some patients who, have really severe symptoms. We've not been able to do that. And on the other end of the spectrum, with some patients who, we thought they were going to be on some medications, but after DBS, they didn't need any. So, it spans the entire spectrum, but usually the average or the bell curve is, on average, we're able to reduce the medications by about 30%. And usually patients are on DBS and medications going further on out. So who is a good candidate for DBS surgery? So obviously they have to have a diagnosis of idiopathic Parkinson's disease. Some folks have other forms of Parkinsonism called atypical Parkinsonism that I'm not going to get into, but they would not be candidates for DBS. They have to respond, they've to had a documented response to levodopa or dopaminergic drugs. Because, that's a good test, and especially during the pre-DBS workup, gives us and the patients a good idea about how well they're going to do after DBS and what all symptoms are going to respond to DBS. Obviously, moderate disease state, again, but that is something that's dynamic, that's changing. Now there is some data, and we advocate for DBS even a little bit earlier than we used to do in the past, because why suffer? Why lose good years of your life suffering through the disease? And if eventually you're going to have DBS, why not have it sooner so you can enjoy, get better years quicker? So age, again, this is a relative thing. It's not set in stone. And the age is a little bit of a factor because of cognitive issues. So if somebody has the beginnings of dementia, then we definitely don't want to do DBS on them because we could make their cognitive function worse. So as a part of the DBS workup, we get every patient to go through neuropsychological testing, where it's a formal, not just memory, but also tests of other areas of cognitive function, executive function, visuospatial, things like that. So we have every patient undergo that, in addition to some of the other testing that we do as part of the pre-DBS workup, and also managing expectations. So I like to have this discussion beforehand with patients before they undergo, like what's going to get better and what's not. A lot of times patients who have really poor balance, even when the medications are working well, come to me for DBS and say like, yeah, everything's good when the medication's working except for my balance. Will DBS help? And usually not. Or if they have a lot of swallowing problems, even when the medications are working well, DBS won't help that. Or cognitive function, as we talked about, DBS won't help that. So I like to establish a clear expectations as to, because it is not fun for the patient to undergo all of this and then at the end of it not be completely satisfied, right? So I like to have those discussions. So when should DBS be considered? I said earlier, so obviously when they're having troubling motor symptoms, which may include dyskinesias, which are the involuntary movements that come when the patient's taking medications, etc., or severe motor fluctuations, which is, you know, when they have ons and offs or unpredictable offs as to, like, you know, they took their medication an hour and a half ago and they expect that, you know, usually this works well, you know, they're out in the store shopping and all of a sudden, bam, the medication quits working on them, like somebody turned the switch off. And, you know, so those are called unpredictable offs. And that's, you know, so if they're having that, or in a few patients I've done it when they've had a refractory tremor, where they have primarily a tremor that doesn't respond to the medications, or if they have intolerable side effects to medications and are not tolerant. I have a very sweet lady like that who was doing extremely poorly before she came to see me because she was not on medication. And I, along with other specialists in the past who had tried, and, you know, we got the same result as they did. You know, she was not able to tolerate any medications. So, you know, as a last ditch effort, we did DBS on her and she's doing very well. Exclusion criteria for DBS, as I mentioned, atypical Parkinsonism, which is a different set of disorders from idiopathic Parkinson's disease, or somebody has a lack of response to levodopa, then that should ring some alarm bells about whether this is truly Parkinson's or not. And obviously, if they have dementia, then we wouldn't do that. I'm going to change gears a little bit and talk to some of the folks who, you know, have essential tremor. So essential tremor is a different disorder from Parkinson's, where primarily it's the tremor, but the tremor can get quite severe. It can be less common at rest, although I've seen patients with severe essential tremor who also have a tremor at rest. But much worse with posture. When they're holding something, you know, their hand shakes, or when they're drinking, it'll cause a lot of shaking. They're unable to write. It tends to run in families. So, you know, for those patients, obviously, you know, they've been on medications, but when medications no longer adequately controls the tremor, then it's a good time to talk about deep brain stimulation for patients with essential tremor as well. These are all the, as you know, Katharine Hepburn was a famous actress who had essential tremor, and you can see that in some of her later movies with shaking in her hands and as well as her head and neck. But these are some of the activities of daily living that the tremor can interfere with. For example, with handwriting, drinking, anything that requires fine movements, dressing, speaking. And a lot of patients who I see have told me they've, you know, stopped going outside because they find it embarrassing and tend to become socially withdrawn and things like that. So, you know, at that time, I think if their tremor is refractory, not being adequately controlled with medications, then it's a good time to talk about DBS, or if it causes social withdrawal, and as long as they're medically stable to undergo surgery. Now, even with Parkinson's tremors and things like that, and especially with essential tremor, if they have unilateral tremor, then there is a relatively new procedure called MR-guided focused ultrasound, which is a lesion where they use ultrasound to make a lesion in that area of the brain, and that controls the tremor. Although keep in mind, you know, even though it's marketed as it's not a surgery, it doesn't involve cutting things open. It's irreversible. Once it's done, it's done. But there is good data that shows that for patients who have unilateral symptoms, that may be a good option. But if patients need bilateral tremor control, if they have bad tremor in both hands and need both sides well controlled, then you know, DBS is it. So, you know, just like your medication, DBS needs adjusting too. This is a slide that I got from Abbott. Access to care is still a major barrier. And this is where, you know, I'm going to transition into the kind of the new development about telemedicine, because, you know, here at Mayo Clinic, I have patients who travel from Alaska, who come from North Dakota, and, you know, many from Colorado. So from a lot of different places. And some come from rural areas, you know, where they may not have access to, forget DBS specialists, even movement disorder neurologists. So I think with this remote programming and telemedicine and all that, I think it's a big, a step forward in us being able to deliver better care for these patients. Also, for some patients, you know, who live within Arizona, who have to drive 2 and 3 hours to come see us, I think having this ability to do that is great. So, you know, as you all know, as many patients that I see have already been using telemedicine, especially since the onset of the pandemic, you know, there's some data out there which shows that before telemedicine, before the pandemic, you know, there was like about, 9% of visits used to be telemedicine. Now, in the first 6 months of the pandemic, 63% have been using telemedicine in some form or the other. So there's been a huge, huge jump in telemedicine, which is great. I think, genie is out of the bottle. It's not going to go back in. So I think I'm hoping at least that telemedicine is here to stay, because it's going to be a huge help, huge benefit for our patients. And, you know, all 3 DBS systems have some form of telemedicine. So, you know, when I use the term telemedicine loosely, we were doing some form of it even beforehand, where patients would call us over the phone. They would describe their symptoms. We would have had given them leeway in terms of their programming, and then we would walk the patient over the phone to be able to turn up or down the settings on their system. So that's, you know, in the medical world, it's called asynchronous care, where patients self-adjusted after discussing with us. Medtronic has a Percept system now where they can record brain activity, and we can tie it to what the DBS settings were when they were off or when they had dyskinesias. So, you know, gives us better information. And then when they come see us, we can change the programming based on that. Boston Scientific, which is, you know, so Abbott and Boston Scientific are the 2 newer systems that have the directional DBS electrodes. They have a Heart Connect system where they could be in a local physician's office, and we could, a DBS specialist, say from Mayo Clinic, for example, can remote in with that physician, and based on how the patient is doing, we can see them over video. We can make recommendations to adjust the settings that the physician there or the representative from Boston Scientific can make those adjustments in person, things like that. So, you know, there are these kind of systems available. But recently, in the past month, the Abbott Infinity system came out with this Neurosphere virtual clinic that I'm going to spend a couple of, because that is true telemedicine, and it's new. I've worked with 2 patients on it because it just came out in the last month, this system. But it's true where, you know, the patients were in their home. I was in the clinic, and, you know, I could examine them, and I could make adjustments to their DBS system myself, or with my nurse in our office, with the patient being in their home. There was no middle person involved. And this is what it looks like. This is the patient programmer, where the patient can see the doctor. This is the programmer that I have, where I can make changes, and I can see the patient, and I can toggle between these 2 views, where I can see the patient and examine them, and then make adjustments to the patient setting. So that is true telemedicine, which I'm excited about, because I'll be able to deliver better care. I'll be able to have more visits with my patients, because imagine, like, as you know, so many of folks in Arizona are snowbirds, where they leave during the hot summer months. to go back to Alaska or, other better, more pleasurable places. And, if I had to make adjustments to their settings, I would have to have them fly into Arizona and things like that. But now I can do this over telemedicine. So I'm definitely excited about it. And, we can, we'll open up the discussion in a minute and you can talk more about it. But it needs a good internet connection, appropriate symptoms. Obviously, the patients have to be tech savvy to be able to manage that. And obviously cognitively able. If they have dementia and they're confused, then, we don't want to do that. And so on and so forth. So that's it. I know I went a little bit over time, but I just wanted to give a good overview of that system. And I'm going to now stop sharing my screen and we can talk about this or anything else that you want. So thank you so much.
Fantastic. Thank you so much. That was actually a really great overview, because I think based on some of the questions, Dr. Mehta, you can tell that some people are newer to DBS and some people are not. So it's really nice. We kind of all have a base understanding then and also kind of understanding some of the innovations, which is super exciting to be able to have some of these innovations. I have a list of questions that have come up. So I'm going to start by reading those and then we can open it up for discussion. How's that?
Sounds good.
Okay. So one is, does DBS help with GI issues?
One second.
Sarah,
Just
go
one
ahead.
second.
Sure.
From Mr. Edwards texted me, are you accepting new patients? The answer is yes. Okay.
Yes.
Sorry.
And that's okay. We will definitely put your contact information in there. And actually, I'm really glad that you asked that, Henry, because I'm actually going to pull this up. One of the really exciting pieces, and Dr. Mehta and I have been talking about this, is it's exciting to be able to have the opportunity for telemedicine. And, last year with all of our programs that we did, we reached into all 50 states and people who've really truly not had an opportunity to connect with medical experts. And just as we've been saying, you definitely need to connect with a movement disorder specialist like Dr. Mehta. You need to definitely connect at least once a year, even if you see a general neurologist. You're not cheating on this person, I'm telling you, I promise you, to see the highest level expert. You deserve that. Same is true for, when you're looking at a surgical option. And I shared with Dr. Mehta that, I've decided I'm going to get my care from Mayo Clinic. It's 2-hour drive, but I can do my visits when I need to, and it's priceless. And I work, and I can do telemedicine for other visits. So I think that we can take advantage of these opportunities. And I'm just going to put a little plug in. Keep your eye on your emails because we will be keeping you posted about some new laws that are being presented and potential regulations that could impact the availability and coverage for telemedicine. And we don't want to take away the opportunities that we had. So I just have to put that plug in because we'll be reaching out to you, I'm sure, to ask for you to get involved and let your legislators know that, this is something that should stay past the pandemic as an available tool for people. All right. So questions. Does DBS help with GI issues like constipation and slow digestion? That's
a great question. Not typically. I wouldn't do DBS on somebody if their main issue was constipation. Although I've heard from a few patients that, it did help them. So, but again, that would not be a main reason to undergo DBS for, because just constipation, as you know, can predate the development of motor symptoms of Parkinson's disease. It is one of the it can be one of the premotor symptoms. Whatnot. So yeah, but that would not be the main reason to undergo DBS.
Okay. Do you have thoughts about second opinions to review current systems and look at fine-tuning your system if you currently have DBS?
So that's a great question. And I'm going to be straight and honest with you. And this is going to make me sound like a jerk, but I'm not like completely a jerk. Maybe just a little bit.
You're not a jerk at all. I can say that.
No. So this is, this is the issue. So with DBS, one, we've had like long-term relationships with our patients. Typically most physicians like to have and continue managing the patients that we've ourselves implanted because we knew, where they came from, what their main issues were, why we did the DBS, when we implanted it, how well did the surgery go. We were confident that we have it in the right spot, things like that, when here at Mayo Clinic, I've seen patients who've had, DBS implanted elsewhere and, and then for years, and then, it's like trying to reinvent the whole wheel as to how did they do after the initial surgery, what were the issues, what all programming has been tried, because, there are millions of permutation combinations, right, that can be done. Was the lead perfectly placed in the right spot? Is that why, or not? Is that why you're not getting a great benefit? So, there are a lot of those kind of variables that make it very hard. I've had some patients where, I'll tell you, not too many, thank God for that, where we've actually had to explant. We've actually had to take out the old lead because it was not in the right spot and wait for it to heal and then put another lead back in the right spot and things like that. So, when it's, or if, when it's, not us who's done that, it becomes much more challenging. Now, having said all that, I'll tell you, I have patients who had, many patients who had surgery elsewhere and they were doing well, everything was good. And then they moved to Arizona and they need a doctor and they need a DBS specialist because, somebody to watch over it. And, I've taken on those patients because, what do? You can't tell them like, no, they need ongoing care. And then, we continue to manage them. But when the DBS results are not good and the expectation is for us to troubleshoot, it's less rewarding for the patient, because we may not get anywhere because we don't know what was tried by the previous specialist and whatnot and all that, but so I'll stop there.
That's great because there were a couple of questions like that. So I think that's really helpful. Somebody wondered if DBS helps with dizziness and balance.
So dizziness. So when you use the term dizziness, what I understand, and I could be wrong, but when a patient tells me dizziness, I ask them, do you feel lightheaded or faint or like you're going to pass out when you sit up, or when you stand up from a sitting or lying down position? If that's what, because is the blood pressure dropping, things like that, because, Parkinson's can affect the autonomic nervous system as well. If that is the case, then DBS will not help that. Now, you talked about balance. Now, balance, as I mentioned when I was talking, is if it is, so you do well at all times, but your balance is poor only when the medication wears off or when the medication levels are low. And that's when the walking and balance gets worse. But when the medication's working, even for a short time, even though you may have limited good on time with levodopa and other medications, but if at those times the balance is great, then DBS will help the balance. But if your balance is affected, and this happens, we see, patients who had Parkinson's for like say 30 years or 25 years, have had medications, have had DBS for 10, 15 years, and, their balance is affected. And at that point, the DBS is not going to help the balance. So it depends on what it is. So if it's on meds, if the balance is good, but it's bad off meds, then DBS could help it by giving you more on time.
And Dr. Mehta, I think what you're just talking about right there is that fine, it's that art, right? There's the art and the science of like that balance between the medication and the surgery and getting it exactly right for each individual person. I always feel like it's a mixture of an art and a science. Do you agree?
Absolutely. That's what I say. It's same thing with medication, DBS, or Parkinson's disease. It's a combination of both art and science. And that's why, different specialists may do it a little bit differently too. We're in the Valley, we have, a lot of good movement disorders, neurologists and things like that. And they so it's not necessarily every time that one's wrong and the other one's right and things like that.
Yeah, and this is really why you want to see a movement disorder specialist, because I believe movement disorder specialists are the most comfortable with understanding those nuances and how they fit
Nuances,
together for
exactly.
the individual person, right?
Right.
And for those of you that don't know, a movement disorder specialist is a neurologist with advanced training in Parkinson's and other movement disorders. So I always say, it's kind of like if you had a particular kind of cancer, you would want to go to the specialist who knew the most about your particular kind of cancer, not just a general oncology doctor, but somebody who knew about your cancer. I think it's the same thing, and you deserve that same level of expertise for Parkinson's. So somebody asked, how long does DBS work? Does it work for 10 years? Does it slow the progression of Parkinson's?
So yeah, I get that question all the time from patients in the clinic when we're here to talk about DBS or who are considering DBS. So it's not like, this is what I tell, it's not like DBS stops working. So the second part of the question, DBS typically, as we understand it right now, does not stop the progression of the disease, okay? So what happens is after having DBS for 10, 15 years, whatnot, it's the other non-motor issues that become more, that also become prevalent, like cognitive impairment or the autonomic dysfunction, like the dizziness or lightheadedness with standing up, or the balance problems and falls and things like that. So, those continue to get worse and are much more of a problem, more so than say the dyskinesias or the bradykinesia, the slowness of movement or the stiffness or the tremor, because DBS handled all of those. Now, 10, 15 years ago, when they first had the DBS, those were the main issues, which it helped, so it's not like it stopped working in 10, 15 years. It's still helping with those issues, but these other issues are now are much more prevalent and taking precedence, basically. So that's the thing. And it does not, at least to the best of our knowledge right now, and I think future research might show something different, we don't know, but to the best of our knowledge right now, it doesn't stop the progression of the disease, so it's going to continue to progress in whatever rate it does in everybody. But a lot of research right now is actually focused on that question. So the holy grail right now, we have surgical options, we have medications, multiple medications with which we can keep treating the symptoms and, have good quality of life for many years. But it's the disease progression, disease modification, or neuroprotection, those trials, and there are several of them going on. That's the holy grail right now, which I'm hoping that we'll be successful at in a few years, hopefully.
Yes, hopefully, fingers crossed, exactly. This is a question about essential tremor. Does it work on both sides, or do you need to choose a side?
No, we typically do it for both sides with DBS. So, we have patients who do a lot of, who are very handy, who do a lot of work or in the house with tools or woodworking. We have artists, who like to paint and draw and, things like that. I have a patient who works on model airplanes, I have a patient who works on cars. So, they need both their hands to be able to do those fine motor tasks. And so, yeah, it's very, very common that we do both sides. But if somebody, it's not necessary that both sides need to be done. If somebody has just a unilateral tremor and not much on the other side, then we can do it just on one side.
Okay, perfect. And I'm going to do a little call out. Ken Schiff, who said telemedicine is great now, we just need it to be continued and convince politicians. Yes, agreed. And he also had a question for you. What parameters can a patient control? So looking at that telemedicine programming, what parameters can a patient control? What ones can only the clinician control? And why would some be
typically
one?
We give the patient, by and large, in terms of the amplitude, in terms of increasing the power or reducing the power. As clinicians, we don't want, one, I've always told, our patients to call us and talk to our nurses to get an understanding of what's going on and to see if it's going to help them or not or what. And if it's something that we can't help over the phone, then we get them into the clinic or whatnot. But usually it's the amplitude where we give them a leeway where they can go up and down. So we can give them a range within which, because, we don't want to make it open where if they keep increasing, then end up with terrible side effects or issues. So we give them a certain range or leeway that they can increase. But now with telemedicine, we could just see them in their homes and change whatever needs to be changed.
Thank you. Hey, I just noticed, Mark, did you have a question you wanted to ask?
I did. I put on the thing already that I already have a DBS. Can it be retrofitted with the newer versions?
Right.
So you already have a DBS, and are you doing okay with that?
My balance is pretty bad right now. Other
Right.
than that,
So
I'm
I
doing
don't
okay.
know, but I mean, again, I think this is not something that I can just answer like right away. I think this is a longer discussion, probably, that we can meet offline or have an appointment or something. But again, I wouldn't just go about do brain surgery on somebody just because there's a newer version available. It all depends on how you're doing and what problems are you having and what not. So because at the end of the day, this is brain surgery. I don't take this lightly. I advise my patients not to take it lightly. So I wouldn't say if you're doing reasonably well, if you had a good response over the years from DBS, then putting a newer version is going to be magical. I don't know. But again, that's a longer discussion that I have to better understand what's going on, where you were, what DBS helped, where you're at right now. So it's a difficult question to answer.
Thank you.
Thank you. Okay, so there's a question too about, and actually while you're answering this one, I'm going to ask Kelly. I know there was a question about how do you get a little more information about the telemedicine piece. Maybe you can show that one slide while Dr. Mehta answers this one question. Somebody asked, is the reason that it's not really indicated for somebody over 75 just because of surgical risk for somebody over 75, or does it not work as well?
So no, it's not. So I like I said when I was in one of my slides, I showed you. It's a very loose. It's a loose or a relative contraindication. It's not like set in stone. Like if you're over 75, that's it. No, because we've done. We have patients who were 76 and we've done them because they are a very healthy. Other than Parkinson's, they don't have much other problems. In the pre-DBS workup, they didn't have any cognitive issues. They did well. So it's not set in stone, but it's the cognitive aspect of it is what usually worries us, that if they're older and they've had Parkinson's for longer and they've had cognitive issues for a while, then we don't want to do DBS because we could make it worse. So I wouldn't say that it's like set in stone that if you're over 75, we're not going to do it no matter what. That definitely is not the case. But it's
okay, because Walter agrees with you. Walter says that age is just a number, but that's great. Thank you. Somebody just asked, and it's a great question. So I have trouble typing, swallowing, and walking. You've talked a little about balancing. Will DBS help when you're thinking of things like typing and swallowing?
Again, it depends on when that happens, right? I mean, it's going to take a broader discussion of how do you do with your medications? How do you do with when the medication's wearing off? Do you have dyskinesias? Are you having problems because of dyskinesias, or are you having problems because the medication wears off? Things like that. So I can't just say that, yes, you should definitely have it done, things like that. But I think it's definitely warrants a discussion.
Okay. Let's see.
Sorry, while Sarah is reading, I know it's vague, but it's very hard to be specific with some of these questions like that. So my apologies.
Absolutely, it is absolutely for sure. I think difficult to you're talking to a really broad group of people, so
Right,
we don't
but,
want to be too
and
specific.
like, by and large, I want you to understand, what we talked about, the medications not lasting, the motor fluctuations, the dyskinesias. And if all of those happen to be a problem, then, and it's because of those issues that you're having more symptoms and more difficulties with your activities of daily living, then, DBS is definitely something that you should consider, you should talk about and open the discussion.
Absolutely. And I stole the screen from Kelly. Sorry, Kelly, that was rude. I didn't even tell you. But under our website, we have under resources our treatment options. So if you want to learn more, there's always information that you can read to your heart's content. Of course, we have all different medications that are FDA approved for Parkinson's, primarily for the medications. But under the surgical, you can definitely look up the surgical options, watch videos about them, and learn more about it. So feel free to visit the website at any time as well. And again, it's just pmdalliance.org. If you go to treatment options, you'll find that, because there's a lot of information out there. And I think, as Dr. Mehta's kind of been talking about, it's the conversation, right? It's what you engage with your physician that matters, that conversation that you have. So somebody asked, do you have to make an appointment to see a new patient in person, or can you just start with telemedicine when you're talking about looking at DBS? That's a great question.
Yeah, so that is a great question. I think, again, it depends on where you're located and all that. So I think doing it first with telemedicine, just to get an idea, is definitely fine. And if during that discussion that we need, like, okay, you know what, if it becomes clear, like, no, you know what, DBS is not an option, then, it's done. And you can go back to your other movement disorders, neurologist or whatnot. But if it feels that, you know what, no, we should, then it could lead to an inpatient visit where we dig a little bit deeper, we have a more in-depth discussion, things like that. But I think as a matter of convenience now with telemedicine, just having a first visit that way is definitely fine. I've had that, I've done that.
And I'm going to just mention, because, again, we've had many conversations about the opportunity that this provides for rural options. One of the I can't say a lot of good stuff has come out of COVID, that is for sure. But the telemedicine truly is one of the things. And there is something called a telemedicine compact that does allow, so Arizona's in the compact, and there's about 25 states that are in the compact, which allows doctors to see patients in other states, and their license is already covered then in the other state. That's a really big deal. One of the biggest barriers for telemedicine, which of course is wonderful to have telemedicine, but if you can't practice in another state because of your license, that's a problem. And so the telemedicine compact does allow for that. And so, if you are listening and you are in another state, I saw somebody who talked about, I could travel to El Paso, but, trying to figure out where to go. If you're navigating this, you can always feel free to reach out to us. We will do our very best to help you link up with somebody that can serve you and can work with you. We have movement disorder specialists in all of the different states, and we know the ones who are in, like I know that with Mayo, like you said, you serve people all over, and especially since you have Mayo clinics in multiple different places. So let me find that link for you, Ken, about the telemedicine compact. One of the things I was going to tell you too, there's been a couple questions about general DBS, speech, that kind of stuff. Right. We'll send a follow-up message to you, and we'll include some information about some of the other videos that we've had about kind of deep dives into DBS too. But do you want to talk a little about the speech issue? Because I know that's one of the things that's hard.
Yeah, and I saw that question pop up on the chat. So, that's a good point. So I've also, and many other specialists, seen that, after DBS, it can affect your speech a little bit, especially years down the line as we keep ramping up the settings. It can affect your speech, where it can make it sound a little bit slurred or thick-tongued, and that can be a side effect. Also, I've seen a problem sometimes, again, thankfully it doesn't happen too frequently, but rarely, a problem with balance after DBS, and so that's why a lot of typically it doesn't happen. So I don't like routinely send everybody for physical therapy right after DBS or anything like that. But if the patients notice, and it could be just from having undergone the surgery, effect of anesthesia, things like that. But that is another thing that can happen also. So I just wanted to put that out there. I mean, there are risks to adverse effects of programming. There's, small risks from the surgery as well. I mean, anytime you put anything in the brain, right? So, but yes, that can happen. But most of the patients who had like a severe shuffling when off or a freezing of gait when off after DBS, because it smooths out those motor fluctuations, at least in the immediate future, like 5-10 years, do quite well. But then, they continue to have the balance issues, whatnot. And it's difficult to say whether it's just from a function of their DBS settings. Some of them it is, or whether it is a function of just the progression of the Parkinson's disease. But yeah, but that can be a side effect of programming, especially at higher settings. When that happens, we try to change the program, try to move the stimulation away from certain areas, or try different contacts, things like that. Some tricks up our sleeve that work some of the time. I'm just being honest.
Excellent. Thank you for that. Somebody asked a question too about telemedicine, and they happen to live in a place that has some spotty internet service, which even if you live in a city, it can be spotty.
Yes.
But they're wondering if that impacts the ability to utilize telemedicine.
I mean, that is, I mean, it's ideal to have a good high bandwidth or a broadband connection internet, because that's great. But and obviously not having good internet, it would be a deterrent, because and forget about DBS. I've done telemedicine consultations with people where I'm examining them over the video, and like assessing their bradykinesia. And then, it freezes, or the images, and I don't know whether they slowed down or they didn't slow down, and things like that. One good thing about this Neurosphere virtual telemedicine programming platform is that initially, when we start the session with the DBS programming, it sets the current, or we can set one of the settings, probably the setting that you are at, that you joined the session with, as a protected program. So if the internet is disconnected, or we drop, the internet drops, automatically your DBS will revert back to the settings. It won't have the settings, what I was trying to do, or changing the settings, that won't take root, because if you were to have side effects with the new setting and the internet dropped and I wasn't able to see that, you don't want to be stuck at those settings, right? Because that can be quite detrimental. So it automatically reverts, because the session didn't end appropriately. It automatically reverts back to that protected program, which most likely is the one that you came on. So obviously you were on those settings for a period of time. So it couldn't be all that bad. Yes, it wasn't ideal. But so from that standpoint, it's not dangerous or harmful. And also, end-to-end encrypted, because you don't want, it to be hacked and somebody to mess with your stimulator and things like that. So that obviously, since FDA approved it, they've looked at all of those issues and have, after that, blessed this system to be used on a wider basis. So
that's really great to know. And you're right. So it's whether or not it's ideal versus harmful is the question. And also the telemedicine function can be utilized on a cell phone and use cellular data too. So that is another option for people. Obviously, it's a smaller screen for the doctor to use, but it can be used, a little more It can be used on a cell phone. So, wow, this has been amazing. I knew that we would fill an hour with no problem with questions, and there's some that we couldn't even get to.
And Sarah,
But what I will,
I'm
yeah,
okay
please.
with, just because, audience is fantastic. They have so many questions. If it's okay with you, I'm okay going over another 5 or 10 minutes. It's lunch.
Okay,
So
fantastic. That's wonderful. Thank
because I
you
don't
so
want to,
much.
leave people without. I mean, I want to answer as much as I can. So I have no problem.
Oh, that's
going over time
fantastic.
if it's okay with you and you don't have any
Oh,
other
absolutely.
commitment or
That's
engagement.
amazing. Thank you. And we'll put Dr. Mehta's contact information in the chat again for you if you want to contact Dr. Mehta. And let me see. I'm going to go back then because there were a couple questions that I didn't know if we would get to, but
And while she's looking at the questions, in full disclosure, I'm not drinking beer or anything. This is just bottled water.
Oh, I had that once. I was drinking actually a little bit of Diet Coke out of a short little glass, and somebody's like, "Hey, you're enjoying some wine." I was like, "No, I'm really not. It's Diet Coke." So let's see. There was a question about closed loop functionality, and I'm going to completely admit I don't really exactly, I'm trying to find it, but maybe can you just explain what that is, and maybe I will find it.
Yeah, I think that's a very a deeper dive. So that's, that we talked about some of the newer advances in DBS, where closed loop, where I think it's in the future, where the percept system, again, based on my understanding, where it takes on the local field potential data, the firing pattern, and based on that will deliver stimulation based on what you need. So need-based things like that. But that's coming as a part of the newer advances in DBS. So where it's need-based or need-driven stimulation and things like that. I also see one question that kind of is alongside this, since I brought up the perception. There's somebody talked about use a constant voltage,
Yes,
voltage
I was
versus
just reading
constant,
that one.
yeah, constant current. I don't, I wouldn't worry about that. Constant current is, so back when we started with the older Medtronic system and all that, it was constant, it was a voltage-based system, but then with the advances, everybody moved toward constant currents, and that's what, we're doing now. So I unless, it all boils down to how you're doing at the end of the day.
Yep.
It doesn't matter what it is. As long as you're doing well, I would continue with that. If you were having problems, then, all of these switching to constant current system, different programming types, interleaving settings, things like that can be, need to be explored. Then one needs to get much more creative with programming and things like that. Okay.
Makes perfect sense. Anne asked a really good question, and that was, can you elaborate on the mechanism of the 4 rings in the directional system? Like, how does that work?
So it basically stimulates, I have some other slides, but so it basically, so for example, I'm holding a pen here, and like I showed you in the electrode, it's got a ring up here, another, and a 4th one, for example, and we can turn one on, the other one off. We can turn a couple of them on at the same time, but when we turn it on, it's going to send stimulation or current or voltage in all of those different directions. But with the directional lead or the segmented lead, the second and the third are in complete rings. So they're not connected. It's not a complete ring. There are 3 segments. So we could selectively turn just this one on, and it would send most of the current in that direction. So, this is useful in the sense when patients are having side effects, because as you use higher strengths of stimulation, a higher amplitude, you are going to stimulate a higher territory, right? Even with directional DBS, that current will spread a little bit into other areas also. But because it's less than what we would normally be sending out, the side effect profile is a little bit favorable.
Perfect. Somebody asked an excellent question too, which is what is the battery life for the controller for DBS? And
That's a
somebody
great
sent me a
question.
private message asking about, do they get any equipment to help with this?
So that's a great question. So I tell everybody again. So for example, there are different sizes of the battery. There are two different sizes. So about on average about 5 years again, but the length of the battery depends on the amount of stimulation, that the amount that you pull, right? Amount of the stimulation or the strength or the settings. The higher the settings, the faster your battery is going to drain. So I've had patients in the past who had like such, who were so much further along and whatnot, and they needed a battery replacement every year and a half. Now, thankfully, Medtronic and Boston Scientific both have rechargeable DBS systems. So that's really good, because that lasts much longer. Can go much further beyond the usual 5 years. Can go up to 8 to 10 to even longer in terms of time frame of stimulation, and that would be regardless of the strength of stimulation. Except with the rechargeable system, some of them have to charge for a couple of times a week for several hours, things like that. So there are great options, and now with the technology being advanced, even with some of the patients who have had the older batteries, with an update and things like that, they'll see on their controller that now end of life is like 10 years out or 15 years out, just with an update. So I think that is evolving, and that's getting better and better every day. So but there are many options in terms of that. So I have some, younger patients in their 50s who undergo DBS. I tend to put them rechargeable systems, so that way they're good for over a better part of a decade, and don't have to come in for frequent battery changes and things like that.
If you're not hearing that there's really exciting changes and new innovations in DBS and in the field of treatment options, then you're going to want to replay this like over and over, because we are so fortunate to have some really great innovation coming. I'm going to ask one more question that was in there that and then I think we're going to probably wrap it up, because then we're going to get ready, because our resilience online community group will be starting in 20 minutes for people with Parkinson's who want to join. But one question was, and I think it's an interesting question that I actually haven't heard in other DBS talks, and that is, so doctors usually say try to avoid surgery when you have Parkinson's. So obviously this is a surgery. So what are your thoughts on that? Is this because this is a treatment? Is that not necessarily applicable?
Right. So I definitely wouldn't, like I said, it's not something that one should be frivolous with, and, but this is a treatment that's going to lead to the improvement of their symptoms. So I don't think that when they say you avoid surgery, that this is included in that. I would not, because your Parkinson's specialist is going to make the determination whether surgery is appropriate for you or not. And second point is that, avoid surgery. Again, it's not like avoid surgery at all costs. I have patients who had, like terrible spine issues, or if they're inching towards, cord compression, which is going to render them paralyzed in their legs, or if they have such severe, terrible back pain that the quality of life is like next to zero, then what am I going to accomplish by doing DBS if they can't walk at all because of their terrible back pain? So, it's not like avoid surgery at all costs, but like if it is something that, if you didn't have Parkinson's, if you were completely healthy and you would, go like get your knee fixed quickly, then, if you have Parkinson's and therapy is going to be an issue and all that, then I would say try conservative management first and only do surgery for the knee as a last resort or your back as a last resort. So it's not like I say like surgery at no cost, at absolutely no surgery ever. It's not again set in stone that way.
Because really, when it comes down to it, for anyone with any health issue, it really is all about quality of life, isn't it? I mean,
Right.
it really
and
is.
It's all about a risk-benefit ratio, right? With everything, every medical decision that we make, be it medications, be it surgery, be it DBS, be it any other surgery, it's all about the risk-benefit ratio. Is the benefit going to outweigh the risk? And if the answer is yes, then you proceed. If not, then you don't. So
I think that is actually a perfect way to close, because I think that is, all of these are just treatment options, as we always share with you, whether it's a medication or a surgical option, and how fortunate we are to have so many options for everybody's unique issues. It's just absolutely wonderful. There's so much information we can share. We will follow back up with you with a link to this, because as we said, it is recorded. It's a lot to take in and process, and a lot of information was covered today. I cannot thank you enough, Dr. Mehta, for being with us and actually staying with us longer to answer these really important questions. We are so fortunate to have your expertise and also just to kind of share your thoughts about how you process all of these kind of things. Right. We're grateful for our partnership with Mayo, and just really grateful for you. And the way we like to end our programs to express our gratitude is that we like to give you a big wave from all of us. So if everybody can give a big wave to Dr. Mehta, and I can't wait till I can see you in person, but thank you so much for being with us today. Thank you, everybody. We look forward to seeing you.
Thank you, Sarah and Kelly, for organizing this and for inviting me. I really enjoyed it. It was very nice to see some familiar faces in the audience. It's awesome that I get to see them. So look forward to seeing you guys in person. Bye.
Sounds wonderful. And thank you, Abbott, for bringing this to us. Thank you so much, everybody.